Hello again. This is Dr. Alan Winter, and I have as my guest today, Dr. Art Gleiner, and we're going to talk about denial, specifically as it applies in the case of the death of Steve Jobs. As you recall in my essay last week, I reviewed the history of his medical history of being diagnosed with a form of pancreatic cancer and his refusal to have surgery for a period of 9 months in which he treated himself with alternative therapies. And today we're going to talk about denial and how that may have impacted his medical decision making so that we can learn from this experience to understand how sometimes patients may delay care or make inappropriate decisions. So, Art, do you have any thoughts?
I think denial is one of the most difficult things that physicians have to deal with in their practices because it comes up in so many different contexts and settings, and there's so many assumptions that people make about their care that it can often, in this time crunch of a typical encounter, the idea of denial sort of gets lost. And there are all sorts of assumptions that get made by physicians about what their patients understand or don't understand about the care that they're getting. So it's very complicated and a very interesting dynamic.
So, to talk about Steve Jobs' denial, there's an environment for denial that we see as physicians. Wouldn't you agree, Art?
The environment is whether or not the patient understands what the physician's agenda is and what the relationship is between the physician and the patient. There are all kinds of assumptions that are made, but they're not always congruent in terms of what the physician expects and what the patient expects in terms of the relationship.
And certainly if the physician feels that the patient is there to discuss surgery and the patient is there to discuss possible options to get better, then that mismatch can be problematic.
I think that's a very good description of it, yes. Yeah.
How does this come about? Yeah.
I mean, I think that's especially true when the physician and the patient don't have a previous relationship. And in the case of Steve Jobs, it was very interesting that he was seen for a kidney stone and ended up getting referred for a discussion about cancer surgery. So there's obviously a very clear mismatch there in terms of expectation. And I'm sure that was very shocking to somebody like Steve Jobs to realize that he didn't fully understand and must have been quite shocked by the environment that he found himself in. Particularly being seen by a surgeon who was somebody who had a lot of authority that Steve didn't have, and that he found himself at quite a disadvantage in terms of being able to understand the context of what the recommendations were.
Clearly. Some of this goes back to the locus of control of healthcare, as we discussed previously, that when medical decisions come up, what doctor-patient style do you as a patient feel comfortable with? The doctor should tell me what to do. And I think a lot of surgeons are very much in the mindset that the patient is here for surgery. And that's what they assume that the patient is accepting. While as there's other patients who want the doctor to discuss in detail the decision. And thirdly, there's patients who I would submit Steve Jobs was who just wanted the information and then he would decide. And in fact, he took the information and decided not to have surgery, which is typical of an empowered patient.
Yeah, I think I find it fairly easy to put myself in the position that Steve Jobs was in, being, a very well qualified and intelligent person, and being confronted with somebody who he doesn't have a relationship with and doesn't have a pre-existing expectation about how the relationship is going to result in a decision, and feeling a need to express his control over the situation himself, without understanding really what the consequences are.
Clearly. So I think it would be reasonable to consider the elements of denial. And I think the first one is clearly fear. Would you not agree?
Absolutely, especially fear when you're not expecting that surgery is one of the things that you're going to require, and there hasn't been an adequate or a sufficient case made for the need for surgery in that circumstance. Being told that you need surgery from somebody who you have no existing relationship with could be a very daunting experience, to say the least. I can see all kinds of different responses on the parts of patients to being in that situation.
And certainly the desire to avoid anxiety and distress is one of the basis of denial, that it's just so much anxiety that you can't face it. I mean, would that be a fair statement?
Yeah, I think even the most prepared of us, faced with that kind of anxiety, would be wanting to escape from that feeling of not being in control. Yeah,
And a desire to maintain a sense of normalcy and control.
absolutely.
I mean, I think Steve Jobs was famous for um, wanting to control the situation in many instances. So that's pretty appropriate, I think, in terms of what happened.
Yeah. I have a lot of empathy for Steve Jobs in that situation, um, to be faced with that. It's difficult to know from the description exactly what the time sequence of the events were, but I mean, he had come in to an emergency room with a lot of pain, so he was already compromised, at least to some degree, in terms of his ability to exert his own control over the situation. And then to be exhausted by the pain and fearful about what the pain might have meant and what might be necessary, and then be faced with meeting somebody new who he had no previous relationship with, a previous understanding about who was in control and what the expertise was, would be a really difficult situation to be placed in. Yeah.
Certainly, his loss of control was, if you start in the emergency room, you have pain, then they relieve the pain, and you're sent to the urologist, and you get an X-ray for what you think is a kidney stone, and then you're sent to a surgeon to have an operation. That's pretty dramatic. So I would expect somebody who needed control would find that just overwhelming.
Absolutely. Yeah.
So you can kind of understand what happened in that sense.
Yeah.
So then we have to think about his levels of insight, and certainly he he wasn't very far down from complete denial to slight awareness to more awareness of being sick to awareness of the illness due to whatever, and then the intellectual and emotional insights that have to develop. And apparently, it took him 9 months to go through these level of insight before he decided that it was appropriate to have surgery. And then we see non-compliance, whether in his case it was probably an intentional non-adherence, because it's not that he was forgetting or misunderstanding or had unintentional adherence. He was clearly chose to skip treatment. So that becomes, how do we look at that in terms of what are the root causes of non-adherence? And maybe we could go through those and see how they apply. The first is certainly psychological distress. We've kind of talked on that a little bit. That depression, anxiety, and illness identity significantly reduces adherence. Knowledge and beliefs. Now, he had some real beliefs about therapeutic benefit of self-care and mind over matter that were real based on his previous experiences with vegetarianism and his interest in Eastern medicine. So these were real as well. And of course, we just touched on this. The physician-patient relationship can't be emphasized enough. Would you agree, Art?
I think the physician-patient relationship is absolutely critical to having good outcomes, where the physician's recommendations need to be followed. But it requires that you have established some previous standard and some previous expectations about what the relationship is. When you're seeing only specialists for your care, and it's not even a situation where there's a clear delineation of how you got to see that specialist because it was so unexpected, there's not a lot of opportunity to build the relationship and to build the trust that's necessary to expect that there was going to be any compliance on the part of the patient, especially not immediately for something major like surgery.
That's a good point. That it took 9 months for that relationship to occur, it sounds like. And most of the time, the patient is sent from a primary care doctor who then, if explains that he or she is sending the patient to a surgeon and sort of prepares the patient for what the surgeon's going to say. But in the case of being referred from one specialist directly to a really advanced oncology surgeon is skipping a lot of steps that is the normal process of care, in which you would have some levels of understanding being imbued by other people.
Yeah, I think you can't really emphasize that factor enough in this situation. Had he been referred by somebody that he trusted and had a relationship with first, it would have made a whole enormous world of difference to Steve Jobs in terms of his ability to trust in the recommendations of a surgeon. Yeah, there's no question about it.
I agree. I think the normal process would be you send the patient to the surgeon, and then the surgeon discusses it, and the patient just refuses to do what the surgeon asks, and the surgeon's always going to send a note back and say, yes, I've scheduled the patient for surgery. Or in this case, I would suspect that the surgeon would call the primary care doctor and say, he's totally denied surgery, and I think you need to maybe talk to him some more about it and maybe understand why, and maybe increase the issues with patient education or getting more to the causes of denial as we will discuss.
Yeah, well, I think Alan, you and I are both primary care doctors, and I think we understand the value that that primary care relationship has for achieving compliance and achieving communication with patients. Because a lot of specialists are, while they're extremely talented at what they do, don't have the same skills with relationships that the primary care physician has with the patient. And that makes all the difference in the world in terms of it, getting people to understand and accept and feel comfortable in the situation that they find themselves in.
Right. I think that's a point that's well made, and certainly the doctor-patient relationship is important in outcomes as we see here.
Yeah. Well, it's important for compliance, but it's even more important for the psychological state of the patient, because patients who accept the need for treatment and have confidence in that treatment are more likely to have positive outcomes than people who have doubts and are not able to be fully compliant, even if their intention is to be fully compliant, because just their doubt creates another barrier to their being as compliant as they should be with any given treatment regimen. Being prepared for surgery is a big deal, because you have to be prepared emotionally and physically to comply with it, and you have to be in a good frame of mind to go through a major problem or major outcome like having surgery and having a general anesthesia.
Because the side effects are real. I mean, side effects are real, and that sort of thing may not be in the surgeon or mind, but it has a lot of impact on the patient. So that's another cause of non-adherence. Another would be financial or logistical barriers if the patient has difficulties getting to surgery or complex regimens. And then finally, cognitive impairment relative in some adults. But clearly, I think in the case of Steve Jobs, the last three are really not the causes of non-adherence. I think the first three, the psychological distress, his knowledge and beliefs, and the physician-patient relationship issues that we just alluded to, I think are the causes. Would you agree, Art?
Absolutely. And one can only imagine the difficulties of going through months of knowing that you have cancer and that the cognitive dissonance that you develop, knowing that you've made your own decisions about what to accept and what not to accept in terms of recommended treatment, and know that you're going to have to live with the outcome of that, can only have an adverse effect on your ability to do self-care.
Certainly.
Your ability to sleep well, your ability to eat well, your ability to exercise are all impacted by your own dissonance about the situation that you find yourself in.
So what could have been done, I guess, is the question. And the best thoughts I had was, what are the interventions for noncompliance? First, we know that education and shared decision-making is certainly important. Explaining the purpose, the benefits, and what's going to happen to treatment is a critical item. And I think instruction is valuable. I don't know who was doing patient education, but as we just discussed, the primary care physician is usually the one that does this. And it's unclear that Steve Jobs had a primary care doctor.
Do we have any information about that, actually?
Well, it's not mentioned in Walter Isaacson's biography at all. He just said the doctors. So that doesn't single anyone out as he did the surgeon. So that area is somewhat not clear. Sometimes non-compliance is because it's too hard to do things. And there can be management of adverse effects. And what I did think was interesting was that in Isaacson's biography, he describes his relationship with the physician who did Jobs's liver transplant 5 years later. And he had a very close relationship with that physician, and he managed these very complex regimen of post transplant medications and treatments, which are probably the most complex in the field of medicine. So he was able to manage the side effects of certainly a very severe type of problem. The psychosocial, I think, support for depression and anxiety and distress is very important. It's unclear who was providing that in Steve Jobs' care. Certainly, in non-compliance, sometimes there's pharmaceutical issues, or technology can help with reminders and so forth. But these are not the problems in Steve Jobs. I think clearly, in his case, we can pretty much say that the initial issues were in education and decision making about expected benefits, and also the depression, anxiety, and distress, which led to his decision to delay surgery, which in my opinion, ultimately cost him his life.
Yeah, I think that's absolutely the case. I think you're right on target there. I think this is another good example of why primary care as an underpinning for all of the care that he received would have made a huge difference for him. In terms of the initial recommendation for surgery, if he had had the additional weight of somebody that he trusted making the recommendation and being there to support him and helping him through the mixed anxiety and depression that I'm sure he must have felt, because he was not immune to those kinds of issues. I think it would have made a world of difference in terms of the care that he got. So,
well, it certainly could have helped significantly. And the other thing, the reason I don't think he had a continuing relationship with a primary care physician is the Isaacson biography noted that he had recurrent difficulties with kidney stones, which when I have a patient with a kidney stone, I always spend a lot of time explaining what the cause, what the etiology is, explaining how if you put too much sugar in the iced tea, it goes to the bottom, or if you put too much sugar in a half a glass of iced tea, it goes to the bottom, and how that you're have to dissolve those things in the liquid, or they're going to go to the bottom. And when they go to the bottom, that's kidney stones. And unless you drink water and keep the glass full, you're going to have kidney stones. And just looking at your urine to tell the color is a simple way to prevent kidney stones and dehydration. And obviously, he was never given the simple explanation of, you look at your urine. If your urine's yellow, you didn't drink enough water. You need to go drink a quart of water and see if it improves, and continue to drink until your urine is clear. And if your urine is yellow, you're not drinking enough water. And he had recurrent kidney stones. And it tells me that no one ever told him that, which leads me to believe his patient education resources were minimal.
Yeah.
Perhaps, as we've talked about, because he was treated largely by specialists and never had a regular doctor over a course of a number of years. And I think that might have made a difference in the scenario that he found himself from quickly being diagnosed with a kidney stone all the way to life-threatening cancer surgery. I mean, probably a Whipple procedure is probably the worst, one of the worst surgeries that anyone can entail as far as complexity. I mean, that's a 12-hour operation, and it's fraught with a lot of difficulty. So you could go from being very well to all of a sudden being confronted with the worst option in medicine. I can see where that was just overwhelming.
Yeah, yeah. Well, I think what you're saying is such a powerful argument for the need for good primary care relationships, because primary care would have overcome a lot of the miscommunication that occurred that led to his needing that, and probably he might still be alive today if he'd had a good primary care relationship that was able to help him make good decisions all along the way. And the lack of that relationship, I think, is foundational for all the difficulty he had. I mean, it's easy to point fingers at this, but really nobody's at fault, because people were thrust into situations that they weren't prepared for. Neither, I think, as good as the surgeon was who saw him at what he did, he wasn't prepared to be a primary care physician to him. And if he didn't have a relationship with a primary care doctor prior to this, that's a flaw of the system as well. I mean, primary care gets poo-pooed a lot as being an unnecessary level of care and unnecessary expense. And I think this really underscores the value of primary care from the relationship point of view, in making sure that things go smoothly and good communication occurs at every level.
And that when it doesn't happen, you continue to contact the patient and see them and talk to them about the issues and check on what they're doing and where they are in that level of insight, and bringing them along from through denial, basically. And that is so critical in terms of making sure that patients are adherent. I think we'll close with that. And next week, Art, I'd like to suggest that we talk about denial on the part of physicians and how that relationship is part of the doctor-patient relationship, has an impact on outcomes as well. So,
And I'd like to add to that the importance of continuity of care, because so many people these days are subjected to a discontinuity, even at the primary care level, that they're seeing a different provider each time. So we should include that in the discussion as well.
we will. So thank you very much, Art, and I'll see you next week. Bye.